Dear ladies and gentlemen, my name is Cornelia Lass-Floerl, and it's a great pleasure for me to give a short comment on molecular-based techniques to diagnose Candida infection in adults. But before we step into detail, I would like to stress out two main issues. First of all, there exists various methods that are available on the market to aid the diagnosis of candidemia or invasive candidiasis. And secondly, when it comes to the blood cultures, we need to differentiate in between culture-dependent versus culture-independent techniques. And this has a strong influence on sensitivity and specificity. Let's focus on culture-dependent molecular methods, as shown here on the slide. They are designed to identify yeasts in positive blood cultures. And generally, the fungal load is enough because the blood culture is already positive. We have a good sensitivity, we have a rapid identification, and identification correlates very well with the phenotypic identification. And the processing time depends on different assays, but varies in between 90 minutes to 3 hours post-blood culture positivity. Using all these methods, you should be aware that there are tools on the market which cover only a few Candida or even only Candida albicans versus targeting multiple species. And all over, the drawback using this method is simply reflected by the drawback that the blood culture itself has a very low sensitivity, which varies in between 40 to 50%. And this you can see also here on this slide, quite a good sensitivity and a good correlation. Completely different is the usage of culture-independent molecular tests, which are used or designed for a direct testing of blood, of serum, of plasma, and other clinical specimens. There are several drawbacks. First of all, and I think this is the most important one, that the fungal load is low in such specimens, is low in blood, hence the analytical sensitivity or the so-called limit of detection is the critical issue. And this is the major difference between judging culture-dependent methods. Most of these culture-independent assays targeted the blood, but all over, I think it's fair to say that only a few patients were enrolled in the study. As you can see here, for any population investigated on Fortune, they just enrolled 27 patients, or Makiti, they enrolled around 49 patients. But what we can learn from this study is that repeated testing will increase the diagnostic outcome. And even if we use the combination, for example, with the beta-D2, with the beta-D-glucan test, this only moderates the outcome. The detection all over can be improved by using a pan-fungal PCR. This is preferred when, specifically when testing with limited availability, for example, tissues, just to be sure that being broader than focusing only on a few species. But all over, when we have a closer look to the studies provided, given the range of available assays, I think it is unclear if the performance varies significantly for the different Candida species, but what we know that it is probably also highly influenced by the underlying patient population. So there are different methods, and the total turnaround time, they strongly depends on whether there is automation or not, what is the DNR target source, whether it's fungal free or fungal cell or free DNA, or the need for sequencing or for outsourcing. And even the usage of the various extraction kits may influence the results. In addition, what we can learn that by a study done from Lyon in 2016, as given here, that there might be a lots of PCR false positivity when patients are colonized with Candida. Hence, these authors, they recommend a combination with the biomarkers. On the other side, using all these methods, it's clearly that PCR specificity can be increased through conventional positivity, and even in low prevalence settings with candidemia, the high negative predictive value supports PCR to rule out invasive candidemia. And a little bit another method in the past was the T2 PIA system. Well, this method, I think, was extensively analyzed, underwent good clinical validation, and was preferred over in-house methods. But just a few days after the Candida guideline was published, it was clear that this test will be taken off the market and is no longer produced. Hence, I do not want to comment further on. So I'd like to come to the conclusion, which is that molecular-based techniques is moderately supported in patients at risk for candidiasis, and that there is a need in the judgment of these tests to differentiate in between culture-dependent and culture-independent methods. Thank you very much.